Come in.
Hi, Dr. Ali. Can I ask you a question, please?
Oh yes, sure. Oh, Hassan, hi. Have a seat, please.
Oh, thank you. I would like to discuss with you the result of Mr. Ahmed, the one who had a right hemicolectomy about 1 week back.
Yeah, I think I've seen his name on the MDT list for tomorrow.
Yes, correct. Actually, the pathology report is released now, and the surgeon are asking whether we should give him any further treatment.
So what does the report say then?
Well, the report actually staged him as a T3N0 tumor.
How many lymph nodes removed?
They removed about 12 lymph nodes. None of them were positive. And they said that he has a lymphovascular invasion positive, perineural invasion negative, but he has a microsatellite instable disease. MSI-H.
Microsatellite instability.
Yes.
Okay. Margins clear?
Margins are clear, yes.
So what are you going to give him then? In stage 2 colorectal cancers, the following features are considered risk prognostic features that have to be checked to evaluate the benefit of adjuvant systemic therapy. They can be divided into major and minor prognostic features. The major are lymph node sampling greater than 12 and PT4 stage including perforation. The minor features are high-grade tumor, vascular invasion, lymphatic invasion, perineural invasion, tumor presentation with obstruction, and high preoperative CA levels. In general, it has been established that adjuvant systemic therapy decreases the risk of death by an absolute 3 to 5% in high-risk stage 2 colon cancer with single-agent 5-FU, and by 10 to 15% in stage 3 disease with fluoropyrimidine alone, with a further 4 to 5% improvement with oxaliplatin-containing regimens. Determining the mismatch repair status in localized colon cancer patients has two objectives. One, to characterize the prognosis and prediction of the benefit of adjuvant chemotherapy, and two, to determine the potential genetic predisposition status of the patient. The mismatch repair high comprises a small subset of stage 2 patients who are at a very low risk of recurrence and in whom the benefit of fluoropyrimidine chemotherapy have not been established, and hence adjuvant chemotherapy should not be indicated in this group of patients.
Mr. Noor, I'm very happy to see you today in the clinic, and I must start by saying you don't look 80 at all.
Thank you, doctor. Thank you. It's a combination of healthy diet, exercise, and stress-free life. But as you know, it didn't save me from this bad disease, and I got it.
Well, I'm sure the surgeon has filled you in, and actually we found cancer that's fortunately in somehow early stage, and if it wasn't for the 2 lymph nodes that were found positive, I don't think you needed to come and see me at all.
Yeah, the surgeon told me, but he also told me that I might need to have some chemotherapy. Is that correct?
Well, that's true.
Okay, well, I have to tell you, doctor, that despite of my fitness, I do suffer with diabetes, for which I take 3 medications. I also suffer with high blood pressure and arthritis. So quality of life is very important to me, and I'm sure that you'd agree with this. Single-agent 5-FU or capecitabine should be considered for the geriatric population. However, and because of toxicity and limited efficacy on overall survival, the addition of oxaliplatin to fluoropyrimidine should be considered very carefully. A number of phase 3 studies comparing oxaliplatin-based treatment with IV 5-FU suggested a limited benefit of oxaliplatin addition in older population. On the other hand, there was no significant interaction by age were detected with oral fluoropyrimidine comparing it with IV 5-FU. The conclusion from these studies that although not statistically significant, patients of 70 years old and above seem to experience reduced benefit from addition of oxaliplatin to the fluoropyrimidine in the adjuvant settings, whereas oral fluoropyrimidine retained their efficacy. Irinotecan has no role in the adjuvant setting.
Hello, Mr. Abdul, how are you?
Fine, doctor, thank you.
Well, as you know, we are here in the oncology clinic today to discuss the result of your testing. You have done some imaging, and from this imaging we have unfortunately found that you have colon cancer, and unfortunately it has spread to both your liver and lungs.
Yeah, I know that, doctor, yeah.
Now, by definition, if you have a cancer that has spread to other organs, this will be an incurable disease.
Oh dear. But is there anything could be done, doctor?
Of course, even if it is not curable, we still can give you multiple options of treatment to control this disease as much as possible. And we have done also some testing for specific mutations that we think are going to be very helpful in the treatment. For example, we have done testing on a gene called PRAF, and it was found to be mutant in your case. And we have done a testing in a gene called KRAS, and this was not mutated.
But what does the mutation in the BRAF gene mean for me, doctor? Mutations in the BRAF gene are found in up to 10% of colon cancer patients and presents a worse prognosis. Patients who harbor a BRAF mutation usually are KRAS wild type because mutations are mutually exclusive. Unlike melanoma, BRAF mutant patients with colorectal cancers do not respond to vemurafenib monotherapy. But data from the TRIBE study showed that fulfixiri plus bevacizumab may be an effective regimen for BRAF mutant stage 4 colorectal cancers. Furthermore, data from BEACON study showed good results to either doublet encorafenib cetuximab or triplet encorafenib cetuximab and blinatumomab in patients with BRAF mutant in the second-line setting.
Well, I would like to present to you Mr. Saad, who is a 62-year-old male and has been diagnosed with unresectable left colon cancer with several liver and lung metastases, and we're planning him for palliative treatment.
Sure, okay, so he's got metastatic left colon with lung and liver. And do we have the molecular profile?
Well, we have sent for all the RAS and PRAF, but the results are still pending.
Good. Well, I know you know this answer to this question, but if we're going to give him cetuximab, do you know which molecular group does predict response to this treatment? The anti-EGFR antibodies, cetuximab and panitumumab, are active in different lines of treatment and in different combinations of patients with colorectal cancer. It has been demonstrated that the potential benefit of anti-EGFR antibodies is limited to patients with RAS wild type. More importantly, it has been shown that the expanded RAS analysis, which also includes detection of mutations in exon 3 and 4 of the KRAS, as well as mutations in the ARAS exons 2 and 4 genes, is superior to the KRAS exon 2 analysis alone.
This is acting for clinical education. Like, share, subscribe.
Don't forget to check the resources down below and join us every Thursday 8 p.m. for more videos.